So the standard treatment for decades for metastatic urothelial cancer has been platinum-based chemotherapy. And generally, chemotherapy in this disease, like some other solid tumors, is continued for a fixed duration of treatment. We tend not to treat until progression in this disease, and that's for a couple reasons. One, because we know if we continue treatment, then we will just start to develop, patients will start to develop cumulative toxicities, and we start to see a diminishing benefit from that strategy, usually at about the 4 to 8 cycle time point. So most of us give 6 cycles of treatment. We stop if the patient's responded to treatment, and that could mean a minor shrinkage of their cancer. It could mean a major shrinkage. Regardless, as long as there's no progression, we stop and we wait. And unfortunately, in the majority of patients, the cancer will start to grow again at some point. And in that situation, we use quote-unquote second-line treatments. And so the concept has emerged: should we wait, or should we take new treatments and start them immediately upon stopping chemotherapy? Now, to have a good switch maintenance approach, a good switch maintenance strategy, which simply means taking a different drug and starting it after chemotherapy, that drug has to have a couple of characteristics. One, it has to have shown some single agent activity, because you want to make sure that you're exposing the patients to a drug that has some activity in that disease. And two, you want the side effects to be non-cross, you want to have a non-overlapping side effect profile with chemotherapy, because if you give someone 6 cycles of chemotherapy and then give them another drug that can enhance those side effects, you're probably not accomplishing a whole lot. And three, you want to make sure that the drug is reasonably well tolerated, because one of the goals of giving treatment in this setting is to extend the response but minimize the treatment burden. That's why we stopped chemotherapy in the first place. So that's really the concept we were testing with immune checkpoint blockade. Can we give immune checkpoint blockade immediately after stopping chemotherapy? It was a randomized phase 2 study. The primary endpoint was progression-free survival. Patients were randomized 1-to-1 to receive pembrolizumab versus placebo. It was double-blind, randomized controlled trial, and the trial enrolled 107 patients. The primary endpoint, progression-free survival, was met. There was a significant improvement in progression-free survival with the use of switch maintenance pembrolizumab. When we designed this study, the treatment landscape was quite different. We didn't even have an FDA-approved immune checkpoint inhibitor in the second-line setting at that time. The landscape is very different now. We have a number of randomized phase 3 studies trying to integrate immune checkpoint blockade into frontline treatment that have already completed accrual and will likely read out within the next 12 months. And so those studies will potentially supplant a maintenance approach by giving all the drugs up front. There are benefits to doing that. There are potential benefits in terms of patient outcomes. There are potential benefits in terms of the ease of use of that strategy, having a one-size-fits-all strategy. But there are some potential downsides to that strategy as well, including giving patients chemotherapy and immunotherapy for a period of 6 cycles, where patients might only be benefiting from the chemotherapy, but you're continuing the immunotherapy. And that's largely because we don't have a great way of selecting which patients do best with which regimens, and simply by giving everything, we don't have to worry about that. So there are some potential benefits to a maintenance approach, but that probably will end up being less relevant in the setting of these randomized phase 3 studies. However, there is one definitive randomized phase 3 study testing the maintenance approach that's completed accrual and hasn't read out yet. So I think the results of those frontline studies and the results of the maintenance study, even though there will be cross-trial comparisons made, ultimately all of that data will be put together to inform the best approaches to combination treatment versus sequential switch maintenance treatment.